Hi, my name's Patrick Mauro. I'm a principal data scientist at Gordian Data, and I'm an advisor to Pearl Health. And I'll be talking to you today about how some of the financial calculations that underlie the direct contracting model are calculated, specifically the direct contracting benchmark. In this lecture, we're going to talk about how the benchmark is used. Primarily, it is used to calculate shared savings payment that you might receive in the model, but it will also creep into how the capitation payments are calculated. And we'll talk about what those terms mean as well if you're not familiar. Then we're going to get into how the benchmark is calculated. We'll take a few seconds to talk about how you can self-help and look at Medicare's very explicit calculations. But we're going to focus on our view, which is just a sort of 40,000 foot view designed to help you get a feel for how this program operates. So just a caveat about that is, we're not going to get into the weeds. If you want to, you can click on the link on the slide. If you scroll all the way down to the bottom of that page, you're going to see all of these PDF files. There are a few other webinars and other materials that you can review, but it's hours of webinars and hundreds of pages of documentation about this program. And we think we've done a pretty good job of metabolizing all that for you so that you can get a view into the program in this presentation. But if you feel like you need to go full depth on any of these concepts, they have some pretty good documentation up here, and you should use that if you find that useful. So another caveat is that we are talking about a very specific benchmark calculation. There are a couple of different flavors of direct contracting entities that are created by this program. We are talking about a standard professional DCE and the benchmark that's attached to its claims aligned beneficiaries. So what do I mean by this? So there are three main axes on which we can characterize direct contracting entities. The first is we look at types of alignment of the beneficiaries. So beneficiaries can be claims aligned or aligned based on claims. And those beneficiaries are the folks that saw you for plurality of their primary care in the previous 2 fiscal years. Now, you can capture other patients as well if you have them fill out paper or electronic forms, and those beneficiaries are what we call voluntarily aligned. There are also 3 types of DCEs. There are standard DCEs, new entrant DCEs, and high needs DCEs. The definitions are here. The easiest way to think about this are standard DCEs are providers or physician groups that have had experience with other risk-based fee-for-service contracts. Some of those sorts of programs are the Medicare Shared Savings Program, Next Gen ACO, Comprehensive Primary Care Plus, and Comprehensive ESRD Care. So if those words sound familiar to you, you might most likely would enter into a standard DCE. High needs DCEs are for folks that have complex needs, including beneficiaries that are duly eligible for Medicare and Medicaid. And if you don't fit into either of those 2 buckets, you're probably a new entrant DCE. Then the third axis is on risk arrangement. And this describes how the shared savings payments that we're going to talk to in the next couple of minutes about how those are calculated, but those describe on how much you participate in those shared savings. So in this lecture, we're going to be talking about the professional DCE, where you split savings and losses 50-50 with Medicare. And in the global program, you capture 100% of savings and losses.
I have a question.
Sure.
When might my benchmark differ from the one that is presented here? Like, so claims aligned beneficiaries in a standard versus professional?
Yeah, and so that's Liz Permenter. I'm joined by a few of my colleagues at Pearl Health, and that is a great question. So you should find this presentation to be directly applicable for you. Again, if you think you already know that you're in a claims, a standard professional DCE with claims aligned beneficiaries. And so whenever any of those things aren't true, you might have a benchmark that is calculated differently. Primarily, a big flag would be if you know that you work with patients with higher needs. Like, for instance, if you have a lot of patients with end-stage renal disease, that will for sure have a different benchmark. Also, if you are a newer provider and you don't have a lot of beneficiaries that might have seen you in the previous 2 fiscal years for whatever reason, those the beneficiaries that would be assigned to you in a direct contracting program would be voluntarily assigned. So you would have to get them to fill out a form. And so that benchmark also differs. And we can cover those calculations in future lectures if there's a demand for that. But those are the two big red flags. So you have bigger or just flags that you would want to, that these calculations don't necessarily apply to you. So again, those are if you have patients with complex needs, like ESRD patients, or if for some reason you weren't doing primary care in the previous 2 fiscal years. Great question. Any more at this point? Great, so we'll move on. So how is the benchmark used? It's primarily used to calculate shared savings payments. So CMS needs a measure of the efficiency with which your patients are receiving care. They're looking at the total cost of care for your patients from their perspective. And so if the total cost of care for your patients was higher than the benchmark in the year in which we're analyzing, the performance year, then you would have generated, say, shared losses, the second bullet point here, and you would need to pay some of those losses back to Medicare. However, what we're hoping will be achieved is that your total cost of care is lower than this benchmark because of efficiencies of care and some care management techniques, and in which case you would generate shared savings, and some of those would be paid to you by Medicare as a bonus. So we're going to get into an example of exactly what that means. Here,
I had one quick question. Are there any other things that might affect how much savings are paid out in a given year?
Sure, that's a good question. And so it's not only just how your total cost of care, where you come in terms of the average total cost of care of your beneficiaries on your panel, but it also involves a quality score. We're not going to discuss that right now, but up to 5% of that total cost of care is attached to the quality score that is attributed to your panel. And if, again, there's plenty of resources online about that. And if you have any questions, our contact information is at the back of this presentation. Just feel free to reach out to us.
All right, so great. And then are there any other risk protections?
Yeah, and so we're going to talk about risk protections in a second in a couple of slides. There's this concept of risk corridors, and there's also a concept of stop loss insurance. And so I'll discuss those in a couple of slides here. So diving into this example of how the benchmark is used, here we are looking at some simulated performance from a provider in the years 2017 to 2019. And we've calculated a benchmark for them. That benchmark is the orange line of this graph. The purple bars are the average total cost of care of their patients in each of those years. So the benchmark here is a little bit over $10,000. And you can see the total cost of care in 2017 was higher than the benchmark by quite a bit. And so some shared losses were generated. Whereas in 2018 and 2019, savings were earned because the total cost of care was below the benchmark. Now, a big caveat here is that we are using a 2021 benchmark to analyze performance in 2017, 2018, and 2019. In reality, a 2021 benchmark should only be used to calculate shared savings and losses in 2021, and that benchmark's recalculated for 2022. But we think that this is a pretty good view into the world of direct contracting and has helped providers understand where they might fit into this program. So diving a bit deeper, just looking at the specifics of these calculations, I love worked examples, is we can look at 2017. The total cost of care was $14,500. If we subtract away the benchmark, about $10,000, we'll get some quantity. We're splitting that 50-50 with CMS because we are a professional DCE in this example. And so we would owe CMS $2,163 per patient that year. In 2019, just looking at that example, we came in at $8,872 for our average total cost of care. And looking at that difference, multiplying by 50%, we get shared savings, a bonus payment of $670. So these calculations ignore risk corridors. That was what I just responded to in one of the things I mentioned when I responded to Justice's question. And so we'll talk about those in a slide or two. Any questions here? All right, great, moving on. So this is the type of analysis that you can expect Pearl to do for you. If you are a provider or a physician group, we can look at where your historical figures would compare to a 2021 benchmark. We can even dive a little bit deeper and analyze what were the cost drivers for those years. So you see in this example, the biggest driver of costs in 2017 that disappeared in 2018 and 2019 was expenditures attached to inpatient care for the panel for this provider. And so we would have advised that we would have tried to dig in with this provider, figure out what was going on in 2017 and what changed, and make sure that that is continued to be realized throughout the program. If you want this analysis done for you, just email the folks at join@pearlhealth.com, and you might be talking to Justice or Liz or one of the other members of our team to cook up this analysis for you and get into the weeds and figure out if direct contracting makes sense for you and how. So now the much discussed risk corridors. So this is one of the ways that that CMS allows you to protect your downside risk in this program. It also limits a little bit of your upside potential. And this works a lot like a progressive tax rate. So as your savings or losses increase, the marginal savings or losses that you capture decrease. An example here, so you can go into the financial reconciliation overview. That's one of those documents that's on the CMS website. Page 13 has this table here and CMS's examples and calculations. But in this example that we just looked at in 2019, we would have gotten $669 PMPY in shared savings. But with the risk corridor applied, we only get $481 PMPY. The worked example here goes through these equations, goes through the math. You can do that if you want to. But you see here that it limits the upside that we get in 2019, and it would have limited the upside in 2018 as well. But it would also have limited the amount of shared losses that we had in 2017. So this is one way that we can control our risk exposure in direct contracting, and it's built into the keel of the program. They also have stop loss insurance in the program, so that if there's a specific beneficiary that has a acute condition that year or their chronic case gets much worse, and they end up costing Medicare a bunch of money, you're only on the hook for that up to a certain amount. Any questions here? Great. And so then the last way that the benchmark creeps into the direct contracting program is through the capitation payments. And so through capitation, rather than having variable payments made to you by CMS every month for your fee-for-service claims, you'll get a payment that corresponds to the average evaluation and management spend over the first 9 months of the previous calendar year. That's an awful. But basically, what was your average E&M spend last year? That's what you're going to get every month this year. E&M claims are defined by a series of ATPCS codes that are established by Medicare, and so that's what leads into this average. And so technically, and so that's probably a good enough place for you to stop if you want to think about capitation payments. But technically, for the purposes of full disclosure, the benchmark creeps into here in a way that allows CMS to adjust that capitation payment for the average risk of your panel and for any other economic drivers that might change the cost of care in your region or in the country as a whole. All right, so now before we move on into benchmark calculations, are there any other questions? All right. So now we're going to get into how the benchmark is calculated. So forgive me on this slide. There's just a lot of little details that we need to discuss and just make clear before we jump into the calculations themselves. And this just helps level set a shared language for this. In direct contracting, there are 3 years that are used to derive the benchmark. Those are 2017, 2018, 2019. These do not change throughout the program for standard DCE. And those are called benchmark years. Now, the year in which you are participating in direct contracting and you're generating shared savings and losses and capitation, that's called the performance year. And that right now the program is scheduled to run from 2021 to 2026. There's one last concept. This will creep in a bunch of places in these calculations. It's the concept of a member month weighted average. So the CMS determines how many members you had per month attributed to you in direct contracting. And that's the member months. So if you have one patient in your panel for 12 months, that is 12 member months for that whole year. 2 patients, that is 24 member months. And of course, patients might enter and leave your panel throughout a year, depending on if they've moved into your region, if they've moved away from your region, if unfortunately they've passed away. And CMS accounts for all that when tabulating member months. And so the member month weighted average is for used for a bunch of different metrics within this model. And it's just the weighted average of those metrics based on member months. So here, let's say you have, in this example, let's say that you have patients in 2 counties. In County A, the patients are a little sicker. They have a risk score of 1.5. We'll talk a little bit more about risk scores in a few slides. But just take for granted right now, the risk score is 1.5. In County A, you've accumulated 900 member months through CMS's tabulation. In County B, the patients are a lot healthier, but there are fewer of them. There's only 100 member months there. And so you would do a weighted average of these 2 quantities in order to find a member month weighted average of your risk is 1.4. Any questions here before we jump into the calculations? All right. So if you want to go full depth on all of these calculations, again, go to the CMS website. They actually have some pretty good examples that get into all these tables and show you all the calculations done explicitly. But there are dozens of pages of text you have to read through. It's not necessarily confusing, but it isn't the lightest reading material, and it isn't the most straightforward thing in the world. So feel free to use that as a resource. But we have come up with an equation that's sort of hidden in plain sight and is built into the model. And through the rest of this lecture, we're going to go into each of the individual variables in terms of this equation, define what they are, and hopefully you'll walk away with a sense of how all of these things affect the benchmark that is being calculated for you, the provider, or your physician group. So you'll see the equation is now on the top right, and I'll highlight whatever term that we're talking about right now. First, we're talking about this first term, triple R, the relative regional rate. Well, before we get into what that means, we have to talk about what a regional rate is. And this gets into that member month weighted average thing. It's the member month weighted average of county rates. All right, now I'm talking in circles. What is a county rate? Well, that concept's actually easy. The county rate is the average cost of care for the beneficiaries in a county. And so what a regional rate is CMS wants to know, well, for the counties in which your beneficiaries reside, what is the average cost of care for those folks? So it takes all the county rates and it weighs them by the member months that your panel has in each county. So this tries to capture differences in healthcare use and perform some cost and wage adjustment on what it takes to actually deliver care for your panel. If you're familiar with the Medicare Advantage county rate, this is very, very similar, and that experience will serve you well. So now we get into the relative regional rate. So what is that? It's just the regional rate in the performance year divided by the regional rate in the baseline years. So this is just trying to account for whether or not it got more expensive or cheaper delivered care in your region between the baseline period and the performance year we're in now. And so as an example, if the regional rate is $900 in this performance year, but it was $950 in the baseline years, then we just divide 900 by 950 to get a relative regional rate of 0.947. Cool. Any questions here on calculations about the relative regional rates? All right. So now we'll dive into the next term, or the next variable here, the risk adjustment factor. So, and I guess the title of this slide is incorrect, but we'll change that. So we're looking at the second term here, RAF. This tries to capture how sick or healthy the patients are in the DC, or specifically in your panel, if we're doing this analysis for you. So this uses the HCC RAF methodology with which you might be familiar. In that methodology, the average patient has a risk score of 1.0. Sicker patients have higher RAFs of like 2.0 or more, aren't uncommon, and healthy patients have lower RAFs. 0.8 is it's a number that is good to have in mind. So the way that CMS uses this at sort of like a macroeconomic scale is it says that the future medical costs of the patient are just the risk adjustment factor times the county rate. So it looks at the average cost of care in the county in which that patient resides and multiplies it by the risk adjustment factor. And that's how CMS sort of internally at a large scale thinks about how much a patient ought to cost. Note here is a slightly different system is used for ESRD patients. So this isn't, you can extrapolate some of the concepts here for ESRD patients, but it isn't slam dunk plug and play. There are a couple of issues here. As you might imagine, it's hard to capture all the nuances of a patient's care with one number. This is extremely effective, I think, for macroeconomic sort of analyses, tens of thousands of patients, millions of patients. It's not going to be good for predicting the future medical costs of a specific patient. Specifically, we know that, or we found research that shows that the predicted medical costs from this RAF times county rate calculation have about a 34% correlation with the actual costs that are observed in the next performance year. And again, that's good enough if your CMS looking at an entire country worth of beneficiaries, and it gets a little worse the smaller the panel size becomes. One big note here that is something that we're looking at Pearl and coming up with guidance on is that CMS has imposed rules on how quickly the risk adjustment factor can change. Because if you increase your risk adjustment factor, you increase your benchmark, and so it's a little bit easier to generate shared savings. Now, this is a problem that's been common in these sort of ACO programs in the past. And so they're imposing these same rules that are very similar to the rules that were used in the Affordable Care Act. But CMS also fully acknowledges that in these shared savings programs, like direct contracting, it's going to make it harder for people are going to be looking at these risk scores more with more scrutiny. They're going to be coding more correctly, and that there might just naturally be an increase in the risk score as a result of this. And so they're acknowledging sort of the pitfall of their coding intensity regulations. So, we think that our providers ought to be coding patients for exactly the illnesses for which they have, and we think that's how they would most accurately be reflected. Their care amount would be most accurately reflected in the benchmark. So the next term here is the term H, and that just the H stands for historical costs. And so this asks, how much does my patient cost CMS? So this is just the risk adjusted total cost of care for patients in the direct contracting entity. It uses data from 2017 to 2019. So it looks for the average cost of care for your patients in those years. And a thing to note is that most of the benchmark is derived based on your historical costs. So we'll get into how the regional rate and other things like that feed in, but again, the benchmark is sort of specific for the providers that are in a direct contracting entity. So let's just look at what we've done so far. Let's check our progress. So just looking at the first three terms here, we have the benchmark is equal to the relative regional rate times the risk adjustment factor times H, the historical costs. Now let's just check to see if this is doing the things that we ought to expect it to do. So first, the benchmark increases as the regional costs increase. So if we've experienced the cost increase in a region since the baseline years, yeah, the benchmark's going to go up. All right, that makes sense. Now, if our patients get sicker, we would hope that the benchmark gets higher because it should cost a little bit more money to provide care for sicker patients. And so we see that as well. If the risk adjustment factor increases, the benchmark increases. And similarly, because of that term H in there, the benchmark is largely calculated around the historical costs of a provider. So I'll stop here because this is a good spot to check for other questions. Any other questions?
Yeah, Pat. So if I have a sicker than average panel of patients, am I penalized for joining the program, for entering a direct contracting entity?
Well, yeah, that is a great question. It's one that we get a lot, but at a large scale, no. because those H, again, this H factor, I'll go back a slide. The historical costs are risk adjusted. And so what CMS does when they're calculating this factor is they look at the risk adjustment factor per patient in your panel, and they do the correct calculations to incorporate that risk adjustment factor into their view of your historical costs. So hypothetically, it should not, if you have a sicker than average patient, average panel of patients, that should be accounted for in the calculations that are tied into this benchmark.
So just to tie those two concepts together, would it be fair to say though that if I, through my own, if I'm a provider through my own medical intuition, believe that I have a really sick patient panel, but let's say I haven't really participated in any value-based care programs, not really, don't have a large Medicare Advantage patient population and all of that. So I haven't been doing a lot of risk coding. So if you take sicker patient population and low risk coding intensity in the historic years, is that a bad combination maybe?
Yeah, and that is a good question. And we've seen this with a few of the providers that we've reached out to, is that they unfortunately just haven't had any motivation just due to the way that they've been participating in Medicare to really follow the risk coding closely. And so they end up having a very low RAP score, but they know anecdotally that their patients are pretty sick. And so, they might have a risk score of like less than 1, like 0.8, 0.9, but they know they have a really sick panel that has generated a lot of expenditures for CMS. And that is sort of an unfortunate situation to be in. In that case, the provider ought to start trying to code as accurately as possible so that the risk score can capture the health or sickness of that patient panel. And then, you hopefully that will resolve with time. But if you think you're in that case, again, reach out to us and we'll be your partner in looking at that analysis and trying to figure out if direct contracting is right for you, and if so, how to shoehorn you in. So great question.
Thanks, that's really helpful.
Cool. All right, so now we're going to go and get into the rest of the terms here to the on the right-hand side of the equation. So now we're back to this R term. This is just the regional rate from a couple of slides back, from slide 13. So again, how expensive was medical care in the region in which the panel exists during the baseline years? This uses data. This is important to know. This uses data from 2017 to 2019. It doesn't change. In 2025, we're still using the same value of R here. It is looking at, again, how expensive, just on average, should I expect a patient's care to be based on where I reside and where I'm practicing. So if you look at this term here now, R minus H, that in essence captures the efficiency for which that care was provided. If H, as a reminder, is that average historical cost of care over the baseline period. So if my historical cost of care was less than the regional rate, well, I, for some reason, through care management, luck, whatever, the panel, my panel costs CMS less money than they would have expected. And so then a bonus, this factor is positive. The R minus H is a positive number, and this generates sort of a bonus payment in the benchmarking model or benchmarking calculations. Contrastingly, if my historical cost of care was greater than R, the panel was more expensive than CMS expected, and so the DC will get penalized. So we don't. So the amount at which you get that bonus or get that penalty applied changes with time. And so there's this term W, which is just the weight. It's the percent of in the literal CMS documentation. It's this factor, the percent of the blended benchmark of regional expenditures. So that's just increases from 35% to 50%. All right, so why is this here? This is like kind of crazy. This is where it gets a little obscure. But basically, it's pretty well known. CMS knows that any deviations from the average in the total cost of care, they're largely, acute. These things don't happen and persist for all of time. And we call that statistically, there's some mean reversion of expenditures. And so if your panel was more expensive than average this year, we would expect it to start trending back to the average in subsequent years. Contrastingly, if it was cheaper than average this year, it should get more expensive as time goes on and approach that average again. And so what CMS wants to do with this efficiency term and with W is to sort of start blending in that accounting for that mean reversion and slowly allowing the benchmark to adjust based on the fact that we know cost mean revert. It starts low because they don't want to do this too dramatically at first. So, you know, they're just slowly blending it in. Again, the benchmark is primarily derived from your historical cost of care. And so by starting W at 0.35 and slowly increasing it, it allows the benchmark to primarily be derived from your historical cost of care and slowly incorporate this efficiency term more and more. So then all of that I just described, the W times R minus H, is thrown into what we call a bounding function, which is just another way that CMS is trying to prevent any of these efficiency adjustments from jerking around your compensation and your benchmark too much. And so they're saying, all right, when all is said and done, when we multiply W times R minus H, we are going to limit the effect of that term on the benchmark to be +5 or -2% of the US PCC. All right, so what is the US PCC? That's the, you can think about that as the average total cost of care throughout the country. So they're saying, we're going to go and allow the efficiency term to adjust up the benchmark by 5% of the US PCC or down by 2% of the US PCC, but no more than that. And so again, this is just to allow you to have this efficiency, this mean reversion adjustment without it affecting things too much. So now we've talked about all the things in the equation. And so this slide sort of captures the definitions of all the terms one more time. This is a good thing to look at and just try to tie it all together in your brain. Any questions from the group as we're looking at this? Cool. And so some just key takeaways to try to slam dunk this is the first thing to notice is that the model adjusts for any economic factors that change the total cost of care. It also accounts for any changes in the total cost of care that are driven by the health or infirmity of the patients in your panel. So it does those things about as fairly as you can for a large group, given the levers that CMS has. It's also mostly based on the historical costs for the physicians in the DCE. It does try to account for the mean reversion of the total cost of care, but really goes out of its way to not jerk compensation around too much. And one of the things with that efficiency adjustment is that physicians that were efficient in the baseline years will get a bonus in their benchmark for being cheaper than the region. But if you really analyze the equation longer, you might realize quickly that, well, the benchmark's going to be higher if the physician's total cost of care was just enormously high in the benchmark years. So that is true, but that is likely only a benefit if you are really sure that those costs are driven by acute cases or special situations. So, so in general, we do believe that providers that have a lower total cost of care than the prevailing costs in the region are going to reliably benefit more from direct contracting. But there might be circumstances where you have an extremely high total cost of care in the benchmark because a bunch of your panel was sick at the same time for the same reasons, had a bunch of acute cases, in which case direct contracting still might work for you if you really believe that those acute drivers are going to go away. And so, I'll wrap it up now. You can contact join@pearlhealth.com for custom analysis for your practice or your physician group. You can send me feedback at pearlhealth at data@pearlhealth.com. And again, my name is Patrick Mauro. I'm the principal data scientist at Gordian Data, and you can contact me directly at the email address there. Any questions from the folks joining me today?
This is really great, Pat. I appreciate you taking the time to walk us all through this. Can you just say a little bit more about why acute cases versus chronic cases in the baseline years? If the former is a drive of spend versus the latter, why the former cases probably okay compared to the latter case?
Right. And so I think it's easiest to answer this maybe by going back to this equation. Right. And so right, if we, again, the left three variables in this equation really are the ones that drive most of the benchmark. That's the relative regional rate, the risk adjustment factor, and H, the historical risk adjusted total cost of care. Right. And so if H is higher, the benchmark's going to be higher. But because shared savings are calculated on your performance this year compared to the baseline, like, right, if you knew that H was higher, your historical cost of care was higher for acute cases, then you would expect your total cost of care in future years to decrease pretty dramatically, right? You know, broken hips heal pretty quickly. Treatment for non-chronic conditions, like if they're non-chronic, they're going to go away. So you would expect that your total cost of care to decrease in future years, namely in the performance period. And so if your benchmark is high because of these high historical costs driven by these acute cases, and then you know that your future savings are going to be lower, well, then you're implicitly like you're, you know, sort of a tautology. Then you're going to generate shared savings. Whereas like the sort of other side of this coin, though, is like if your historical costs are high, just because of whatever care management techniques you use, you know, whatever you have a very chronically sick patient panel, maybe you haven't been risk coding because you haven't been in one of these ACO type programs before, then direct contracting might not be for you because your costs are going to be high in the baseline period and they're going to stay high in the performance years. And in that case, it's going to be much more difficult to generate shared savings. So I hope that answered your question, Gabe. Is that clear?
Yes, it does. So in other words, you know, if an acute case by definition is expected to resolve in the future, that cost of care won't be carried forward most likely into performance years. But a chronic case, whether that's managing dialysis patients and the spend associated with that, or patients on expensive long-term medications where it's really hard to change that kind of spend, that spend will persist and make it harder to generate savings going forward.
Yeah, that is a really good summary. So
thanks, Pat. That helps.
Cool. Any other questions? All right. Well, we look forward to having more discussions with providers and physician groups and care managers out there. I think the more people that understand how the benchmark is calculated, the more we can really understand direct contracting as a whole. And so it's our hope through this lecture and others that we're going to have a more educated set of providers out there that can help really champion the program and understand how it can best be utilized. So thanks for joining us today. And again, you know, reach out to us at Pearl Health if you want to continue this conversation and get an analysis that's been customized for your historical costs. So thanks for joining us.